mute, so you guys couldn't hear me, but welcome and thank you for joining me for this webinar on joint injections. Even though the title says hip and knee injections, we're going to focus on knee injections because that's what I mainly do, and in my practice we probably do several hundred knee injections a year. But it's applicable to other joints, all these injections, be it the shoulder, the hip, or the ankle. But most of the literature is directed toward the knee, so that's what I'm going to focus on, and that's what I personally have the most experience with. And just a reminder, use your Q&A to write down and send any questions. Some of these, if they're simple, can be answered by a PA or a nurse during this presentation. Other ones I will answer at the end. Ones we cannot get to will be answered via email. So we'll get started here. So this is just a little cartoon. It's kind of making fun of knee replacements. It says, whatever you do, don't go to Westlake Orthopedics. They totally messed up. Well, it's a double knee replacement. And just to let you know, knee replacements are a big part of what I do. They're great operations as far as quality of life, one of the best operations there is known to mankind, probably outside of plastic surgery. But this talk and the injections we're going to talk about, the main goal is to delay or even prevent the need for total knee replacements, because even though it's a great operation, approximately 10 to 15% of people still have some issues with their total knee after they're done. So we're going to talk about common injection therapies and some minimal conditions that we see in the office quite a bit are soft tissue injuries. Tennis elbow, which is pain on the outside of the elbow, is very minimal to injections. Patellar tendonitis or jumpers or runner's knee. Some hamstring injuries we will inject. But what we're going to focus on really are joint conditions and mainly osteoarthritis, which is OA of the knee. There are certain ligament injuries, such as an MCL injury that's delaying healing, that's amenable to injections. And we also use injections as a surgical adjunct as well. So I'm just going to talk briefly about the soft tissues that we inject. So this is looking at the right elbow from the side. In this area of inflammation is where the tendon attaches for all the muscles that allow us to bring our wrists and fingers up. And people that do repetitive activity, even though it's rarely seen in tennis players, though it's called tennis elbow, can get inflammation in this area. And individuals who have failed conservative treatments respond very well to either cortisone or PRP injections to this. And we'll talk about cortisone and PRP in detail in a little bit. Another soft tissue condition that's very amenable to injections around the knee is jumpers or runner's knee, which is a patellar tendonitis. And people that have failed conservative treatment do respond to injections. We rarely inject cortisone into that area because it can lead to patellar tendon ruptures, but PRP is found to be effective in some studies for patellar tendonitis. Now I want to go over a little knee anatomy because this really sets the foundation for this talk. And the knee is made up of 4 bones, and we're looking at a right knee from the front here with the knee bent at 90 degrees and with all the soft tissue taken away and the kneecap taken away. So the 4 bones are the patellar, the kneecap, the femur up here, the tibia, and the fibula here. There's 4 major ligaments, the ones on the sides called the collateral ligaments, and then the 2 cruciate ligaments in the middle, and that's what gives our knee stability. What we're going to focus on is the cartilage, and there's 2 types of cartilage in the knee. You have this glistening white efficient bearing surface on the end of the bones. It's on the end of the femur, on top of the tibia, here, underneath the kneecap, and that's what allows our joints to work and function very smoothly and efficiently. And the friction of normal cartilage on cartilage is less than that of ice on ice. And the other cartilage is the meniscus, which is between the bones right here, which is the shock absorber. And this little picture here is an arthroscopic picture showing normal articular cartilage, and this is what it looks like under a microscope. It's 75% water, only 10% cells, and this extra matrix, extracellular matrix, is made up of, sorry about that, of collagen, which gives it tensile strength, and these proteoglycans, which are proteins that catch water and give it compressive strength. And this molecule that just left me here is hyaluronic acid. And we're going to talk about hyaluronic injections. And in these areas called the glycosaminoglycans, you have glucosamine and chondroitin sulfate. And you guys have probably heard of those supplements. And those are normal constituents of normal cartilage. When cartilage breaks down, this is what it looks like. You get exposed bone, you get eroded cartilage, you develop bone spurs, and you can see how rough it looks when we look at it and how different it is to that smooth cartilage. So the etiology of osteoarthritis is multifactorial. It can be metabolic, genetic, mechanical, but the bottom line is it leads to joint failure. And you can think of your knee as an organ similar to your heart, liver, or kidneys, and when you get osteoarthritis, that's failure of that organ. So you lose the normal joint homeostasis, the bad cells, which we call the bad cytokines that eat up the cartilage, kind of overpower the good cells when we develop osteoarthritis. So arthritis is the leading cause of physical disability in the United States. It limits activity for over 40 million people, and there's about a 50% chance that each of us will develop some type of arthritis in our lives. And the interesting thing is that 60% of people that have it are actually relatively young. They're under 65 years of age. And it is a huge fiscal burden to the United States, where over $400 million in both direct and indirect costs annually are attributed to treatment or loss of work and disability associated with arthritis. And just remember, aging does not equal arthritis, and once you get it, it's a progressive disorder, and there's really no prevention for arthritis. And if we look at healthcare costs, the U.S. spends trillions of dollars per year on healthcare, which is about 18% of the GDP, which is huge, much more than most countries. And knee arthritis alone makes up about 400 million of this per year. So how do people present with arthritis? Usually they have pain, and usually it's activity related, but they can have rest pain. They can have night pain that keeps them up at night, swelling, stiffness, and general loss of function of the joint. This can lead to depression, it can lead to weight gain, and it can worsen other medical issues that you may have, such as diabetes, hypertension, and others. The diagnosis, usually I can make this just by listening to the patient. They'll present complaining of activity-related pain and throbbing and swelling, and maybe some loss of motion. Physical exam, a lot of times we'll see swelling, we'll notice stiffness, we'll look at their alignment, we'll notice malalignment of the extremity, and a lot of times we'll feel what's called crepitus. When they move their knee through a range of motion, it's kind of that styrofoam rough feeling, and you can feel that just by putting your hand on the knee. Imaging, such as this x-ray right here, is diagnostic. Rarely do we need MRIs to diagnose arthritis. We do most x-rays standing, and in a normal knee, that thick cartilage on the end of the bone is what we call radiolucent. It doesn't show up on x-ray, so we'll see spacing like this. But when it wears out on these standing x-rays, arthritis presents like this, where it's bone on bone. And this is a typical patient. This is a patient of mine I saw recently. You can see the malalignment with her standing. She has knock-kneed, or we call valgus deformity, and she has x-rays that look like this, where you have joint space narrowing. Obviously, she's had some trauma in the past, and these are bone spurs here, and this is typically what someone with arthritis, their x-rays will look like. And what this creates is just an angry, inflamed joint that's very painful. Unlike this x-ray, which shows a normal joint with normal alignment and normal joint space. So the main pain generators in arthritis is what we call synovitis, which is the lining of the joint. It just forms more fluid than it should, and that is a pain generator. And I think a lot of the pain comes from this subchondral bone lesions. When the cartilage wears out, it's not there to protect the bone, and there's more stress on the bone. And on this MRI, you can see the white in the bone here, where normal bone is this charcoal gray. And bone, unlike cartilage that has no nerve endings, bone is very sensitive and has a lot of nerve endings. So when they're swelling in the bone, it's very painful. And you also get altered joint environment, again, on the chemical nature of it, where the bad cells start outnumbering the good cells and they eat up the cartilage. So the management of knee arthritis, many ways to manage it. The non-invasive ways are weight loss, but that can often be a very difficult conversation with the patient. Activity modification, if someone has arthritis and they enjoy weight-bearing activities, maybe getting into biking and swimming or using poles for hiking may be helpful to unload the joint. Physical therapy, a lot of studies show that it's helpful to maintain mobility, strength, and function, but not only maintaining strength in the muscles around the knee, but also hip strength and core strength is very important to unload our weight-bearing joints. And then icing to decrease inflammation, non-steroidal anti-inflammatories, and Tylenol. Occasionally we'll use a non-opioid painkiller if people are having night pain. And then bracing can be helpful. Just like the lady I showed you, when you have malalignment, you can use bracing to help realign or unload the affected part of the knee. Most people don't tolerate it for full day use, but using it for recreational activity such as hiking or tennis, many people do benefit from bracing. What we're going to focus on today is the invasive part of this, which is the injections. And the three main ones are steroids, HA, which is hyaluronic acid, again, a normal constituent of joint cartilage. And then we'll talk some about biologics. And when all these fail, that's when we talk about joint replacement surgery. And this was a study that looked at all non-operative treatments for knee arthritis, and they found that injections actually give the best pain relief and function. And in this particular study, the PRP and hyaluronic acid gave the best results. Probably the workhorse of injections over the years, most common one used are corticosteroids or cortisone steroids. It's all the same thing, and they're just very strong anti-inflammatory medications. And most recently, in the last year or two, we've been using a lot of what's called Zilretta, which is a long-acting, slow-release steroid that should last 4 to 6 months. And it doesn't have some of the side effects of typical steroid injections, which can be increasing blood sugar. If you're a diabetic, or too much cortisone can actually accelerate the wear and tear of that articular cartilage on the end of the bone. So we do a lot of cortisone injections in my practice. The other injection that we've been doing for over 2 decades is hyaluronic acid. And hyaluronic acid is a very viscous substance. It acts as a lubricant and a shock absorber to the knee. But we're also replenishing the hyaluronate, which is altered when people develop arthritis. There's enzymes that break down these proteins and they disorganize the collagen so that the structure of cartilage does not work normally. So we're trying to create a more normal environment to the knee by injecting hyaluronic acid. And this is just a typical cortisone, or this is a hyaluronic acid injection we do right in the office. We have this little spray that you didn't see, and then we inject it.
You know what I'm doing?
And
I can't hide it.
you can do these under ultrasound guidance. I personally don't, because I feel comfortable enough to do them. And the anticipation is usually worse than the injection itself. Now, the other injections that we're starting to do more of are what we call orthobiologics, or regenerative medicine. And this encompasses the PRP, which is platelet-rich plasma, and then stem cells, BMAC, or stem cells that come from bone. You can also get stem cells from adipose, or you could get it from amniotic fluid and umbilical cords. And the whole goal of biologics is really to turn up the good cells and turn down the bad ones. But the FDA is very specific on what we can and cannot do using these biologics. They allow minimal manipulation, so we can't add heat, we can't add growth factors, or we cannot add enzymes. And you have to use it the same day. If you're taking something from your body, you have to put it back in the same day. So I don't know if you guys are familiar, but a lot of great athletes, including the late and great Kobe Bryant, would go to Germany for PRP that was known as Regenikine. And what they would do is they would heat it for like 48, 72 hours. They felt this increased the amount of growth factors in the PRP and then inject it. But that is illegal in the United States. We really cannot manipulate the tissue. But something we can do is we can centrifuge tissue, and this is a centrifuge, and a centrifuge is just an instrument that helps us separate cells, and I'll talk about that a little bit more detail in a minute. So what is legal and not legal at this time in the United States? Hyaluronic acid is legal, PRP is legal, BMAC, which is bone marrow aspirate stem cells and adipose stem cells. What's illegal are exosomes or using amniotic fluid or umbilical cord blood. So those are things that you should not use based on the FDA. And if you look at the orthopedic sales in the last year by product, it's about 50 billion annually. And the majority of this is in spine and in joint replacement and trauma. But if you look at orthobiologics, it's about 10%. And so that's about what, $5 billion a year. And so this is a new, exciting frontier in orthopedics, but it's kind of like the wild, wild west in a way also. And when there's 5 billion annual in sales, you have to be careful, because anytime there's money or the ability to gain wealth, that encourages bad behavior. So all I'm telling you is when you see ads like this that state that stem cells will cure everything, just be careful because they really don't. So even though it's very encouraging, there's really not great science behind stem cells as far as a panacea for curing diabetes, Alzheimer's, cancer, or even curing knee arthritis. So other considerations when we talk about orthobiologics is cost. They're expensive. The average PRP injection is about $900, and I can tell you that most insurances and Medicare do not pay for it. And a lot of the insurance now kind of give us a hard time with the hyaluronic acid injections, and many times we have to get pre-authorization. Medicare is very good, and they'll let us inject Zilretta, that long-acting steroid, and hyaluronic acid without any pre-certification. But other private insurances, sometimes it can be a hassle. And so this is how we do the PRP. This is Rachel, my PA, who's taken blood, about 60 cc's of blood just from the arm of a patient. And then we put that blood into the centrifuge, and the centrifuge spins the fluid. And what it does is it separates the plasma or fluid from the cells. So this is the fluid, these are the red cells, and this is the good stuff up here. This is the mother's milk. This is the platelets right up here that we're trying to get to inject into the patient. And this is just a better picture of it. So out of 60 cc's, we only get 2, 3, or 4 cc's of the PRP once everything is separated. And this is just another way to look at it. Most of blood is the plasma, about 55%. Another 45% are the red cells. And what we call the buffy coat in here is the platelets and the white cells. And there's two main types of platelet that you can harvest. One is what we call a leukocyte rich, where you have a lot of white cells, and that's better for the soft tissue injuries like the tennis elbow, or leukocyte poor, where it doesn't have many white cells, and that's what we like to inject into joints because it's a better anti-inflammatory that way. So what are stem cells? Stem cells are cells that are capable of self-renewal for long periods of time. They're unspecialized cells, but they can give rise to specialized cells depending on the physical and chemical environment that they're exposed to. So these stem cells, if you put them in an environment such as the knee, could potentially turn into cartilage cells, and that's where the term regenerative medicine really comes from. So as of today, the thinking is that the main pain relief by stem cells is actually, it works on the pain receptors, just like if you took a pain pill. We know that they're very strongly anti-inflammatory, but do they rebuild tissue? It's really unknown. It's thought to be very unlikely at this time. I have patients that come into my office and say, hey, Dr. Pevny, I know my knee's wearing out. Why don't you just inject me with some stem cells and let the cartilage grow back? Well, it doesn't, unfortunately, it doesn't really work that way. So the title or the term regenerative medicine is really kind of a misnomer. And this is where we get the stem cells from. You can get them from the back of the pelvis. here. So you put a big needle into the bone, and then you aspirate it, and really what comes out is blood, and then you can put that into the centrifuge, and it'll separate again the cells, and will give you stem cells. It's a process that takes about 45 minutes or an hour. It's something I really don't and have never done in the office. I do it more as a surgical adjunct on selective patients. And the other place you can get stem cells are fat. So you do like a little mini liposuction around the abdomen, and you place that fat into a special centrifuge, and it'll give you stem cells that you can inject into the patient. So our old friend that didn't have such good luck with his knee replacements also had some misfortune with his hip replacements, unfortunately, as well. So even though I'm making fun of hip and knee replacements, they are actually excellent operations, but what we're talking about today hopefully will delay and in some people help them avoid that operation. So let's look at just some quick data and science to see what it shows as far as these injections are concerned. Comparing cortisone and hyaluronic acid, there's really not much difference. If you look at the science, there's no difference in this one study at 6 months. But if you look at the studies overall, the hyaluronic acid may work a little bit longer. You know, cortisone maybe 3 to 4 months, maybe hyaluronic acid 4 to 6 months if you look at it critically. And in patients that have a lot of swelling with arthritis, the cortisone might be a little better because it's a stronger anti-inflammatory than hyaluronic acid. So someone who has arthritis but not a lot of swelling involved, maybe the hyaluronic acid is better, but the literature shows that they're pretty similar. So what about hyaluronic acid versus the PRP? Most studies shows that the PRP is actually better as far as pain relief and function at 6 and 12 months after injection. So PRP appears to be superior to hyaluronic acid. And this study recently out of Chicago showed that if you combine PRP with hyaluronic acid, it actually works better than if you use one or the other alone. So PRP combined with hyaluronic acid is probably better than PRP or hyaluronic acid by themselves. And another study showed that by doing PRP and or hyaluronic acid in people with knee arthritis compared to individuals who did not have any injection therapy, it can delay knee replacement by a median of approximately 5 years. So what about PRP and stem cells? The literature overall shows that PRP is probably better than the bone marrow aspirate stem cells and equivalent to the fat stem cells. And in this study that looked at all three, there was no difference and they were all effective. So PRP was just as good as both of the stem cells. One, it's a lot easier to harvest, less invasive, takes shorter amount of time to do it, and you can do it easily in the office. So to me, looking at the literature, the PRP seems to be the best of all of these. And also this summer, in the Journal of Arthroscopy, which is a peer-reviewed journal, the editor had this quote, and I'll read it. It says, PRP surpasses all other injection treatment options, whether they're adipose-derived or bone marrow-derived stem cells, hyaluronic acid, or salines in patients with knee osteoarthritis. So that's a pretty powerful statement endorsing PRP as the best injection for knee arthritis. But you got to remember, it's not paid for, and many times it's very difficult to convince a patient to have an injection that's very expensive if I can't promise them that it's going to help them. So in summary, as far as the injectables for knee arthritis are concerned, the workhorse is still probably the cortisone-based ones because they're usually covered by insurance, they're easy, they're well tolerated, they're safe, short-acting in both the Zilretta, which is the long-acting, viscosupplementation, which is the generic term for doing hyaluronic acid injections, is very popular, and most of the time we can get insurance to pay for it. PRP, I think, as far as injections, is the gold standard based on the literature and my experience. But again, many people have to pay out of pocket for this. And stem cells, you know, it's like I said before, I think stem cells are this exciting new frontier in orthopedics, but they are a little bit like the wild, wild west. Even though most people think they're a panacea and cure everything, the science certainly at this point does not support that. But I think with further studies down the road and with time, I think we'll find that they are useful in the future for knee arthritis. So just to be thorough, there are other injections that you can do in the knee, but that I do not personally have much experience with. One, mainly because there's not great scientific data to support them, and two, it's just not something that we're taught during our orthopedic training. One of them is prolotherapy. This is used more, I think, by chiropractors and the sort, and this is just injecting sugar water into an area which promotes inflammation, but you need like 8 to 12 injections of this to really work. So it's a lot of injections, a lot of sticking with not great science to support it. Ozone is basically injecting oxygen, which is a very strong, ozone is a very strong antioxidant and anti-inflammatory, but again, multiple injections are necessary, and there's no great level 1 studies that I'm aware of to support its use. Another kind of interesting thing on the horizon, and I recently read a study where it showed it was effective for knee arthritis, is something called cooled radiofrequency, which is a radiofrequency machine, think of it like an ultrasound machine, that helps deaden the nerves around the knee to decrease pain. So it doesn't really affect the cartilage or the arthritis itself, but it basically just shuts down the pain-generating nerves around the knee. So my protocol in people that do have symptomatic arthritis, I try to minimize joint loads, and again, this is with weight loss. For every pound that you lose of weight, the way the physics and biomechanics works, it's 4 pounds off the knee. So it makes a huge difference. You lose 10 pounds and it feels like 40 pounds to your knee. Activity modification, again, people that do weight bearing and impact activity, maybe trying a different type of activity. Correcting alignment, if the arthritis is mainly on one side of the knee or the other, we can use very simple things like heel wedges, or we can use unloader braces, which I mentioned before. Medications, non-steroidals, which are your ibuprofens, your Aleve, your Motrins, your Advils, and prescription ones such as Celebrex or meloxicam. Pain medications like Tylenol. We try not to use opioids, but again, if people aren't surgical candidates and they failed everything, sometimes using a non-opioid pain medication can be helpful. Physical therapy is also in my protocol, which is helpful. And if those things don't work, then we talk about the injection therapies that we discussed. And if that doesn't work, then you're a candidate for knee replacement surgery. And so as far as the injections, I personally do a lot of cortisone. I do more of the long-acting cortisone these days. I do a lot of hyaluronic acid, and in many patients will do the long-acting cortisone, for example. If in 2 to 3 months it doesn't work, then we can try the hyaluronic acid. So we use a lot of them in combination. I do quite a few PRP injections. Most of the PRP injections I do it like that one study in Chicago showed, that combining it with the hyaluronic acid probably gives you the best bang for your buck. I do not do a lot of stem cells in my office, but I do it as a surgical adjunct in certain individuals. So that's my talk, and I will answer some questions at this time. And the other thing I'd like to remind you is to please fill out the survey, and a link to the recording will be sent out tomorrow, and our next event with this Valley University lecture series will be by Dr. Michael Potter, who's one of our upper extremity specialists. He's going to talk on November 3rd about how to prevent hand and wrist injuries this winter. So thanks for your attention.
Thanks, Dr. Pevny. That was great. I have a few questions for you. First question was just wondering about restrictions after PRP, what you tell patients if there's any activity restrictions they need to follow.
After all of my injections, and again, there's no great standards, so this is all kind of anecdotal, what I've done over the years. I have them take it easy for a day or two. You can do your normal activity. Sometimes there's a little soreness the day of the injection, so ice can help over that area. And I let people get back to their normal activity after a day or two. I don't think there's anything in the literature that states you have to rest it for 2-3 days or a week or anything like that.
Great. You touched on this a little bit, but wondering about a preferred sequence of injections, if it's best to start with something like cortisone and then move forward, or how you would make that decision? I
think it is. Cortisone is, not that it's, I don't use it because it's cheap, but it's readily available, it's usually effective, and it's the least expensive, and it's safe. So usually we will start with that, or if I have someone who really doesn't have much of an inflammatory response at the time, someone who has pain, their history, their exam, their imaging is consistent with arthritis, but they don't have a lot of swelling, maybe I'll start with hyaluronic acid. And I'll always do that first, and then if the cortisone or hyaluronic acid do not work, then we'll have that discussion about combining the PRP with the hyaluronic acid. And I have many patients that everybody's different. Some people have mild arthritis on x-ray and are in a lot of pain and have a lot of swelling. Some people have advanced arthritis, which have some pain, not bad swelling. But I've had patients that we've been treating with injection therapies for over a decade, even though I showed that one slide that showed that the median time to prevent or to delay a total knee was about 5.3 years. I have patients that we've been doing these injections that have pretty bad arthritis and been getting by with injections for over 10 years.
So kind of along those same lines, if you've already had an HA injection and they didn't work, is there any correlation to how well PRP would work for you?
I don't think so. I don't think there's a correlation between hyaluronic acid and PRP. If someone did not get any relief at all with the hyaluronic acid, then maybe just doing a PRP injection alone rather than combining them would probably be the next step.
We had a few people wondering a little bit more about stem cells. You mentioned that you don't do them in your office, but for select patients you do use it intraoperatively as an adjunct. How do you decide who's appropriate for that?
Yeah, a lot of it depends on the degree of arthritis that they have, how much bone involvement there is. People that don't have terrible wear and tear of the cartilage but have a lot of swelling in the bone, and I feel that's their main pain generator, then I will occasionally do the bone marrow aspirate, even though I've kind of switched and actually have started to use more PRP in this situation than the bone marrow aspirate, and will inject in the OR. This is at the time if I do an arthroscopy. For example, if someone who's had arthritis, they've been doing fairly well, now they have a new meniscus tear, and we'll go in and scope the meniscus, but on the MRI that showed me they had a meniscus tear, they have a lot of swelling in the bone. We will do a what's called a bioplasty, where we'll inject either the bone marrow aspirate or the PRP into the bone lesion with a very large bore needle. And to me, that's something that isn't tolerated that well in the office setting to begin with. So that's the reason I do that in the OR. I do not take people to the OR just to inject their knee with stem cells. I do it if I have a bone lesion that I want to inject, because studies have shown that injecting PRP and to a certain degree the stem cells can help decrease that swelling in the bone. And if I feel that's a major pain generator, then that's where I use the stem cell intraoperatively.
Great. That was all the questions we had.
Okay.
So I will step in. Thank you again for a great talk tonight. Thank you everyone for joining. Like Dr. Pevny mentioned, our next talk is November 3rd. There's also going to be Another webinar October 20th with one of our physical therapists and one of our athletic trainers talking about some rehab and exercises for shoulder injuries. If you're interested in joining that. You will get a survey after the talk tonight. If you could please fill that out and give us some feedback. And you'll have links to register for any of those future talks. So thanks so much.
Thank you.